Thank you, Professor Gupta, for joining us and to answer some of our many patient questions. Just as by introduction, Professor Diraj Gupta from Liverpool Heart and Chest Hospital, who is also a member of the AF Association Medical Advisory Committee. Thank you.
You're welcome. It's always nice to be chatting with you.
Thank you. So we have some general questions to begin with that patients have submitted. And you're the expert, and I know they want to hear from you. A couple of questions about beta blockers, and they're wondering, are there any restrictions on what you can and cannot eat or drink when you're prescribed beta blockers?
Not really. Having said that, some patients who are on beta blockers experience weight gain. Because essentially what beta blockers do is they slow the metabolism of the body. And sometimes that can promote weight gain. So some patients have experienced that they are more likely to gain weight when they're on beta blockers. So they might need to cut down on their calorie intake. But otherwise, there are no specific restrictions in terms of what you can and cannot eat or drink when you're on beta blockers.
Monitors, how reliable are they? One patient says, I have a monitor to detect tachycardia, but it sometimes says AF is detected. Just how reliable are these monitors?
Okay. Well, that's a very good question, very topical question. There are so many monitors out there in the market. Every month sees the arrival of another one. There are monitors, there are wearables, there are Apple Watches, etc. So we get asked this question so many times. Now, there are differences amongst the technologies out there. Some have been validated in good quality studies. For example, Apple Watch is particularly accurate. It has been shown to be quite effective in diagnosing sustained arrhythmias. Other devices, perhaps less so, but more and more devices are coming up each time. So I think the important thing is that if the abnormality picked up on your device happens to be at a time when you are truly symptomatic, it's much more likely to indicate an abnormality rather than if it just comes as a bolt from the blue and you are entirely asymptomatic. Number one. Number two, if the same abnormality is being highlighted on a number of occasions, then it's much more likely to represent an actual arrhythmia rather than if it is just a one-off. So what I'm trying to say is that it should be something which coincides with symptoms, and if it happens on more than one occasion, then you probably need to get yourself checked out. If on the other hand, it's a one-off recording, happens when you're entirely asymptomatic and not doing very much, well then you probably can afford to disregard it.
Could you tell me, are palpitations and ectopic beats the same thing?
Well, palpitations essentially refer to any perception by the patient of an abnormal heartbeat, so something that's abnormal for them. One form of palpitations is missed beats, which usually refer to ectopic beats. So if the patient feels a sensation of a thud followed by a pause, where they might even feel that the heart stopped for a second or two, and that usually indicates ectopic beats. On the other hand, there can be different kinds of palpitations. For example, sometimes the patient experiences a sudden onset, sudden increase in their heartbeat, which is sustained for several seconds or minutes, or even hours sometimes. That is not indicative of ectopic beats. That might be indicative of an attack of SVT or atrial fibrillation, for instance.
And a patient has heard of catheter ablation for AF, but what other ablations are there and for what conditions?
Okay, well, essentially surgery was the first way to perform ablation for atrial fibrillation. So essentially surgical ablation for atrial fibrillation came before catheter ablation for atrial fibrillation, so about 30 years ago. The reason why catheter ablation became so popular over the years was because of its relatively non-invasive nature. So it's so much easier for patients to undergo catheter ablation and go home the next day. Whereas obviously for surgical ablation, certainly the way surgery used to be performed in the past with the open heart surgery, with a mid-sternotomy, so it's essentially going through the, through the chest, it used to mean that patient had to be in hospital for a week or sometimes longer. Surgery is still sometimes offered for atrial fibrillation, but it's now offered in a sort of minimally invasive ways. So surgeons have kept up with the times, and now they can do the same thing as what they could do 20, 30 years ago, but with much lower amount of invasiveness. So essentially all you have is a couple of small holes on either side to show for it. Having said that, it's still more invasive than catheter ablation, and so it's still reserved very much for those patients in whom catheter ablation has failed. You asked me whether there were any other arrhythmias for which surgical ablation could be tried. Very rarely, extremely rarely. You can use it for difficult to treat ventricular tachycardias, but the number of cases performed in the country, I could probably count them on the fingers of my hands. Very, very rare surgery. So essentially, it's for atrial fibrillation. Surgery is the only other modality other than catheter ablation, but even then, it's reserved for those patients in whom either catheter ablation has failed or where the cardiologist feels that such extensive ablation is required that the patient may be better off having surgery in the first place.
Thank you, Professor Gupta.